So the pattern will be same as we did the last class. I'll be going through questions, and all of you would be answering in the chat. And anyway, we need that some discussion is needed, or if you have any confusions, obviously you can stop me at any time. Last class went really well, and all of you participated really well. So I'm hoping to have the same today as well. So let's get started. So we have a known case of hemophilia A received factor VIII 3 times during this week through subcutaneous implant catheter. He was febrile, tachypneic, and tachycardic, a BP of 100/70. He's on ceftriaxone. What will you add? So what are we suspecting here? And why have, I think I did clear the answers, but I think I got missed in a few. So yeah. Come on, everyone, let's get started and have a good discussion. Yes. So what are we treating in this case? We need to be clear about that. And what is the indication? What organism are we suspecting? So that we are clear that why are we giving what we are giving? Yes, we are suspecting MRSA. And what diagnosis, like why is the infection there? Okay. So I think gradually we'll just gear up and started answering. So here, yes, it's not endocarditis that we're treating. Because we don't really have a history of any cardiac lesion at this point. We do not know that if the child has some carditis or something, but we're treating the catheter-induced infection. And in the pediatric guidelines, yes, Dr. Aminat's line sepsis, yes, in the pediatric guidelines, 2022-24, there's guidelines which says the antibiotic use, and in that you can see that there are multiple tables given to treat the multiple infections. It's a really good one to revise the antibiotics. It has all the important ones like the line catheter, and it is said that in the if you're suspecting anything like that, you have to start the vancomycin. And along with that, ceftriaxone is also given, depending upon, this is like the preliminary. After the cultures, obviously you can change that. So I would ask all of you to go through those guidelines. It has all the important ones, the osteomyelitis, the orbital cellulitis, any of the antibiotics that have to be given in any cases. So that would be really helpful to you. Okay, so go through those guidelines. Okay, so we have an 11-month-old infant with VP shunt, came with the sunken fontanelle, bilateral brisk reflexes, irritability, and spasticity. There was no fever. His heart rate is 110. Respiratory, and what is the cause of these abnormalities? Okay. We have started getting answers. Good, Dr. Tajana and Dr. Adam. I like your enthusiasm. I think you're always very active, Dr. Ali, as well. Yes, so it is shunt over drainage. Why are we not saying the shunt infection? Because there's no fever. Okay, and there are no signs of something like that. Shunt blockage would present with the pressure symptoms. The fontanelle would be like bulging, and displacement, they don't have signs of displacement. So the sunken fontanelle means that more fluid is being drained out. A 3-week-old baby with a birth weight of 3.2 kgs presents after being discharged home with a history of cough, apnea, and floppiness after lying down 3 times during 30 minutes. Each apneic episode lasts for 1 minute. The weight is 3.7 kg. The patient was feeding well with small amount of regurgitation. What is the most likely diagnosis? Okay, good, everyone. Everyone is answering B, which is right, because arrhythmias, obviously child would be having something else. Tracheophageal fistula presents with something vomiting, increase frothing from the mouth. NAI would present with something like headache or things like that. Myoclonic seizures would not be associated with regurg, right? So the good thing is that the way we have to see that the weight of the baby is increasing. It is from 3.2 to 3.7 kgs. And the lying down history, and whenever there's GERD, the